Kathy, shifting gears a little bit to later lines of therapy, one of the most common questions I get asked is, Rego or TAS, why and who and all of that. Give me your perspective on how to play that out.
So in clinic, obviously one of our issues is patients with liver metastasis. So if we have a lot of degree of tumor burden for those patients, that may dissuade me from utilizing regorafenib just because the risk of increased LFTs in that patient population. And then the schedule for TAS is a little bit challenging, but I try to remind patients to take it Monday through Friday. Whether or not one is better than the other and which specific line, I think at the end of the day, you still want to utilize each of the regimens. Originally, unfortunately, regorafenib got a bad name just because of the toxicities originally, but it's come a long way thanks to Tony's data from Redose.
He's already full of himself, so we don't really want to
but it validates what we were already doing, which is basically starting off your dose of regorafenib at a lower dose so the patients could tolerate it better. And then that way, that's another line of therapy for that patient population.
So you've adopted that strategy in all your patients?
We'd been doing it quite a while ago.
Okay,
even before
the data.
Yes, even before data.
Crystal ball could have saved a lot of money.
Now, can I just make a comment that in contrast, though, with TAS-102, it appears that staying on dose and the closest dose may matter.
Yeah, that's a different setting.
Right. So I think that I agree the redose very critical for validating what we do and potentially even a better outcome for patients. But with TAS-102, a different drug has to be managed totally differently.
Yeah, I do crazy stuff, I know, but if I'm giving TAS, for example, and they've been on Bev, I actually keep the Bev going because I see the Rego as having some VEGF already in it. And with the TAS, and based on now these new frontline data randomizing Cape-Bev versus TAS-Bev, the TAS-Bev actually looked pretty good. And this is purely anecdotal, but we've now got some minor responses in that space. So I do think TAS will evolve as a novel sort of chemotherapy, either in combination, may move earlier, this sort of thing. And I think Rego, thanks to Tony's work and others, has got its expanding space as well.
And there was that interesting data with nivolumab too reported.
Yeah.
Plus Rego. Well, I think overall, though, if you look at the dose optimization strategy, it did shift the survival to close to 10 months versus 6 months with 160. And we actually, did a meta-analysis, will be published in Oncologist, that looked at Redose and all the randomized regorafenib TAS-102 study. And so what's clear is that regorafenib 160 and TAS-102 maintain a very similar, because again, it's comparisons through a meta-analysis, very similar outcomes. But the regorafenib dose escalation strategy remains, at least in the survival front, even a little bit of the PFS superior historically. That's the caveat, of course, to regorafenib or 160 or TAS-102.
With both of these drugs, my experience is it never really rescues a patient whose performance status is falling. So I don't even try it in that space. I don't throw the Hail Mary pass. No. But what it has made me do is I want to make sure and use it. So I combine the work from Redose and more comfort with the dosing and the controversial data from Reverse. And even in that patient who's got low volume, metastatic disease, asymptomatic, I might try Rego before I try my EGFR, figuring my EGFR is going to still be active later lines. Anybody doing crazy stuff like that? Are you going to play your EGFR before always?
I've not utilized that regimen.
It's back to the rash, it's back to the magnesium.
Sequence.
If I can wait another 6 months.
The data from Reverse, which is basically what you're mentioning, it looked to have some promise, but once again, I think a lot of us want to see some of that data validated in the United States.
And there's a study that's looking at this Reverse 2, creatively called Reverse 2.
Well, I'm not going after some innate biology. I'm just trying to make sure I get all the drugs in.
It's clear on the right side that since you're going to push your EGFR inhibitors to the end, that's a very clear pathway. I don't disagree that it may be worthwhile to consider this, because if we look at all this cumulative knowledge we know about regorafenib, if you move it a little bit up the line, it actually seems to have a better performance than the lower line. Not necessarily for TAS-102, though.
Yeah, okay, fair enough. Yeah. Dustin, Jeff?
I'm trying to use the EGFR re-challenge more.
So use it, get out. Use it, get out.
Exactly. And so may not be pushing regorafenib to earlier lines, but trying to reuse EGFR later on.
How do you do the re-challenge, though? Just to make it clear, because you know we don't want to have patients just go back on EGFR inhibitors without a biologic driver.
So in my clinic, what I say is that I need to have at least a 4-month PFS on the first time or the most recent time they had the anti-EGFR therapy, and that it's at least been 5 or 6 months since they've had the anti-EGFR therapy. And so in that setting, there's now a number of studies showing that you can get response rates in the 20% range for that re-challenge.
But that's primarily, looking at some of the essentially clones, the appearing and disappearing clones, which is a study that's being done now, the Pulse, which is with EGFR re-challenge. I think that will probably be a better way to select better those patients who may be benefiting most probably from EGFR inhibitors. But that's a poor man's way to do it right now, perhaps.